So today is all about ACL and ACL reconstruction, our guide to post-ACL injury. This is a non-medical view, exercise, holistic point of view of when people are cleared by a medical professional, what do you do? Or if you've ruptured your ACL, what can you expect? We have the bones out here. When people think of the knee, because most people are like, oh, I've ruptured this ligament. The ligament, probably the same as tendons. It's probably the same as all this other stuff, but it's clearly define different things, and why would that matter? So we're going to go on first what happened during an ACL rupture and the pieces that are involved. Number two, what does recovery look like? Surgical, non-surgical. Why would exercise and management of the quality and the control of not just the knee, but how it relates to your entire body, why would it matter? Number one, have you heard of other people having contact and non-contact ACL injuries? Have you heard that before?
No, most of the clients that I've worked with have just said that they have an ACL tear. They don't really say how.
First of all, the ACL is a ligament, and ligaments are supposedly bone connected to bone. And that's, the ACL is going to run from the tibial plateau right here to the condyle, inside of the condyle of the knee. This is my left knee right here. If I have a force that's pushing inward and rotating this tibia, that's usually the mechanism of injury of this if it's a direct hit. Okay. And usually when it's a direct hit, something is slamming in this way. Or somebody's going to take a step and they can't control their body, so then the ligament gives because they can't control this whole thing. But they think it's just happening at the knee. This is just the part that gave way. In this contact, it's retrograde forces through the foot, ankle, knee, which is three pieces, actually four pieces, sorry. You got a fibula here, and then you got a kneecap right here that have to be controlled and managed simultaneously while the foot is hitting the ground. And my brain has got to have a plan to know what to do before I actually do this, otherwise I can't control this with the muscle contraction and the timing. So there's also a timing problem. That's why it's interesting to say, like, okay, I could have a direct trauma to this area. And this ligament tissue, it was grown from one cell since birth, like embryology, that is now loaded with a ton of sensors. And the sensor feedback loop of the ligament now becomes a really big deal for how you control this knee. But because it's loaded with neuronal tissue, with nervous system tissue, there are tubes that has to connect with to your spinal cord up to the brain. And if this gets injured, those neurons can also get injured, which causes swelling, supposedly. Some of the literature says swelling in the spinal cord and possibly the brain. So when you're damaging this ACL, your foot hits the ground, and a majority of these ACLs in the NFL is a great study, ACL injuries from 2015 to 2019. It said that over 70% of these were non-contact, and I think a majority of them are non-contact, trying to step out, trying to turn. The body is having trouble negotiating and navigating time and space efficiently. So anything that messes with time and space and contraction, there's going to be problems. So is an ACL problem an ACL problem? Yikes. Right? And what's also cool in that study are ACL tears only affecting the ACL. From the NFL study, bone bruising were evident in 94.8% of the ACL tears. So there's bone material that's injured. Also stacked with nervous system tissue, mostly in the tibial plateau. The meniscus and cartilage injury was present in 89% of those knees. I should say meniscal tears, not Montana's. Joe Montana's. Meniscal tears are present in 70% of these, lateral 59%, and medial 49%. Additional ligamentous injury was present in 71% of all MRI scans. Lastly, direct contact injuries were 21%. Non-contact, it was 79%. Chondral damage to the bone, right? At 49% of all MRI scans. ACL tears were rarely isolated injuries in the cohort of professional American football athletes. Bone bruises were almost always present, and additional meniscus, ligamentous, and chondral injuries were also common, assuming that these different materials would also heal. If these materials do not heal at the same rate, that means that total body exercise can be leveraged in order to then change how these things may heal, but then also the main problem to begin with. How am I going to control this on command when I already know my body failed to do so, which ended in a ligament rupture? The biggest concern would be post ACL is, in the literature, ACL re-tear, contralateral ACL re-tear, meniscal tears, and the rapid onset of osteoarthritis. There's a whole bunch of data out there that says like 10 years post ACL injury, there's some pretty crazy osteoarthritis out there. There's also some literature that says it ain't that bad. The types of surgeries that are involved are pretty interesting, and I posted a picture of what they do during the surgery, because when people like, we're fixing the ACL, supposedly now recent data that shows that they say 1 in 3 people spontaneously regenerate and heal ACLs in 2 years. So I guess there's a chance, but it's like, do you want to be the 2/3 of the people that don't spontaneously regenerate? You're having the initial onset trauma of the ACL rupture. Now you're going to have a graft placed into this knee to substitute the ACL, which can be done with a hamstring or a patella or other tissues. And supposedly the other tissues don't end up holding up so well over time. Your tissues tend to hold up better. However, a ligament isn't a tendon. So then when you're harvesting a tendon and you're putting it in here, what they're doing is, you can see it, they drill a hole through this bone to try to match the canal of where this guy is coming out of to go into this bone at the same orientation and angle, so that when it's coming through like this, they put a button on the side of this bone and they anchor it into this bone. So now you have an anchor, and this is sewn into and grafted through these bones. So you have the injury of the bone material, you have the injury of the cartilage around that, you have internal bleeding, the meniscus in itself hopefully doesn't get too beat up. You have the joint capsule that also has a ton of neuronal information in it. What I'm getting at is, it's going to take around a year to 2 years for this to get even close to recovering. The muscles then have to coordinate its ability around it. Coming back a year, it would be a minimal time to return to that type of activity. The research says like you're not going to get anywhere closer than around 70 to 80% of what it was before, of the integrity of that tissue, because the ligament and tendon is not the same material. But what is cool is supposedly that tendon, parts of it start to die, and then when forces are placed to it, it starts to turn more ligament-like. So the body starts to actually change how it's working. It doesn't necessarily mean that what caused the non-contact injury would then be changed. So you have the initial contact injury, the surgery, and then whatever control problems were there to result in that non-contact injury. What are some things that may affect this non-contact injury? It's a non-exhaustive list. Genetic predisposition, like the size of the bones, the shapes of the bones, the placement of the ligaments. What else? We call it allostatic load. How ready is your system? Are you in a fatigue state? Are you on a bunch of medications, stress levels, previous injuries, overuse? Are you someone that just crushes your body? Previous arthritis, age, previous surgeries, current activity levels. Are you deconditioned and don't really use your body much? Neurological disease, metabolic disease, orthopedic disease, cancers. And then what's really interesting is temporal spatial dysregulation. Are you having trouble detecting how you even move in space? Eye problems, ear problems, hearing, the inner ear problems, vestibular problems from concussions or traumatic brain injuries or spinal cord nerve root problems, facial problems. Did you have sinus surgery? Do you have foot and hand sensation problems? The feet, ankles, knees, it's like that stuff better have good contractile capabilities. And we're only looking at this stuff via contractile control. Like, how are you controlling it? I guess what I'm getting at is this just a knee problem? How many people are addressing this as just a knee problem? How many times you see people coming back from like knee problems and they're just like, work on my knee. What is pain? A sensation you do not like. And it's really good at helping you protect what's going on. I don't want to move this way, so I got to stop moving this way. Well, then what caused the pain response when you move that way? That's a trigger. Well, how many pieces of that could you look at? So like, where do you start? What are some things that you can do right now holistically to change that? And how to start as far as controlling the different body segments in different ways. Because it will have a total body effect all the time. Because again, muscles aren't just things that move you, they're also sense organs, and they're also glands that release anti-inflammatory mediated chemicals, and they also help with wiring the whole body and how to move in time and space. And people can do that right now. The tendon tissue that had been damaged from harvesting from the other muscles they're now compromised, and they all now have to recover not just the tissue quality, but then how the circuits are wired so that they have better timing, better control, because that leads to feeling okay. Because the pain response means I'm not okay doing this thing.
Everybody's going to go into that scenario with a bias of, man, we're having pain in the knee, and they've had ACL surgery in the last year. Maybe there's something wrong in the knee. Like, I mean, it's just a normal thing to have. And there's nothing that says that potentially there isn't stuff. But is it the main stuff? Who knows? When you're working with clients like that, being able to like have a system to flush some of that stuff out is great. But also getting to the point where you're not looking at other things and how that is impacting the overall function of that part, especially the other side. You'll see that a lot, where you may have a lot of control stability in the knee that's bad, right? The one that just got fixed, and then you go over the other side and it lacks a lot of control in some things.
Yeah.
Our baseball guys this week, like, it's coming off a meniscal surgery where they actually repaired it last year. And he lost a good 13, 14 degrees of knee flexion. And as we slowly over the offseason got that back to being equal and strength is equal, like, I mean, pretty much anything that I could do to that knee, he could tolerate by the time he left. Well, the last session we just did, I always go back and check the other side for control, motion, and all that stuff. And he had very limited control and full knee flexion in the other side. So it does happen, right? Like where things like will bounce back and forth from time to time, which is why you should have a checks and balances system, right? So, you know, now it's nice that we caught that. So I'm going to give him things to do for that, you know, for the season. But it's something he's going to have to continue to maintain because he's less than a year out of having that quote unquote fixed, right? So just something he's going to have to learn to manage. And that's what we talked about all off season is
management,
learning to manage his body better.
Brandon brought up a great point where there was a study by Horga and Hirschman, 2020 MRI, median age 44. Looked at 115 people, uninjured, sedentary adults, asymptomatic knees. So they look at 230 knees. MRI shows abnormalities in 90%, 97% of knees. 97, asymptomatic, no pain. So what Brandon was talking about, well, we had one side that felt pain, so felt pain triggered a scan. The scan triggered a surgery. What were the chances when we looked at rotator cuffs that the asymptomatic side had a rotator cuff tear? It was over 50%. Why not use exercise to leverage control? How does it feel when I try to recover from that stuff? And does my body perceive that by moving differently? In the 97% of knees, this is crazy. 30% of the knees had meniscal tears, 23% horizontal, 3% complex, 2% vertical, 2% radial, and 1% bucket handle. They said cartilage and bone marrow abnormalities were prevalent around the patellofemoral joint, 57% of the knees and 48% of the knees, respectively. Moderate to severe cartilage lesions were common in 19% and 31%. You're still dealing with arthritis up to between 20 and 30%, really. Moderate lesions in tendons were found, and then partial ligament ruptures were found, especially of the anterior cruciate ligaments, and that was 2%. And again, the cohort comprised of 230 knees, uninjured sedentary adults, 51 males, 64 females, median age 44 years. Brandon, when you're working with people and they're not able to recover well, I've been seeing it where they're not really able to even detect it, like their fatigue or where they're at.
When they finally are like, I'm good, and you ask them on a scale of 1 to 10, 10 being the hardest thing they've ever done, 2 or 3, and then it takes 3 or 4 minutes to recover. That's the biggest thing that you see consistently show up with people, where it's just their conscious level of fatigue just doesn't exist. It's like, I could just keep doing this, right? Like, yeah, no big deal. Or it's the interesting one. Like I had a client today who's got Parkinson's, like got some other things going on. Like he told me it was a 2 or 3, and he could only do 6. It's not a lot of reps. Like, and he just literally like could not lift his leg, and it was a 2 or 3. I was like, that's interesting. Like that's what you believe. I mean, it was like he hit a wall. It was good, and then it wasn't. It was like that. And it's like, I'm expecting him to say, oof, it was like a 10, because he just lost it so fast. Like 2 or 3, it wasn't that bad.
So then like the representation of fatigue, just like pain is a perception, fatigue is a perception. The body is working and building waste products. The body's detecting that to create a perceptive state to say like, okay, I better stop now. How accurate is that? If somebody's exercising, and how do they know if they're really tired or if they're really done if they don't practice, am I done or am I tired? Most people are just doing their reps of 10, or they're doing the high rep volume stuff and just pushing through. Why not make that more accurate? We're gonna use exercise, get better at detecting fatigue and position, rather than do one set to failure or 10 or 5. So I want you to find out how you're detecting this stuff with this simple system. And if you're having trouble with organizing it, if you have trouble detecting where you are in space, there may be other things that we can do to help solve those problems quicker, because a lot of people that come in here, either they don't know how to move to begin with and they have no plan to move and they don't know how to organize the movement, or they have trouble detecting fatigue. Those are the 2 biggest problems that we see. And that goes hand in hand with non-contact injuries, where you don't know how to orientate yourself in space to the point where your body just rips. And now it's never the same. In about a year, it's about as good as it's going to get. 2 years, it's pretty much like what it's going to be, and then it's going to max out its ability around 80% with the scar tissue that's in there, if it doesn't get necrotic and fail, which happens too for revisions, which then later leads to advanced osteoarthritis. So how can we help the other parts of the body give support to the knee? What if you work the foot differently? Or what if you work the hip differently? I mean, there's muscles that cross both that also cross the knee. That's directly impacting the knee control. And that's why a knee injury isn't a knee injury isn't a knee injury. An exercise isn't an activity. An exercise is a specific challenge for a specific adaptation where you're aware of it. The activity is when you're on autopilot and you just go. And you wake up stiff, you're probably exerting way too much. What you did yesterday, you haven't recovered from, and now you're stiff. So what are some things that ring out the most to you?
And then even seeing and hear how concussions and TBIs can do issues with controlling everything.
Yeah, it's like people believe that if they've had a concussion years ago, oh, it's healed. Concussions are damage to central nervous system tissue. I don't know if they ever truly heal. They may reroute differently. And those neurons, or those tubes, are connected to various structures to help with timing integrated to your environment of your eye information and your hearing information. That's sensing your environment to create a response for your body to be okay. So if that's lagging, or one eye is controlling differently, or your hearing's a little bit differently, because traumatic brain injury and concussions, they're not the same, but concussions can dysregulate autonomic function of the heart, HRV, control of your feet and ankles, control of the vestibular apparatus for balance, dizziness. There's so many links towards brain trauma. And if you see like female soccer studies, heading in soccer and ACL injuries are linked. I wouldn't say that they're causal, but
Yeah.
they're definitely linked.
Wrong place, wrong time,
Yeah.
wrong force. Something's got to give. Right? Doesn't have to be off a ton.
Yeah.
It's like you go back and you see, like, I work with a lot of baseball players, like elbows, shoulder injuries that happen, like, and you go back to concussion stuff, and you will see timing problems. It's like throwing is about timing, being at the right place, the right time. Things are off even milliseconds. It doesn't have to blow it. All it has to do is cause little micro damage over and over and over until it gets weaker and weaker and weaker, and then boom, done. It's an accumulative effect. You've lost that timing where you're on time, and that gets worse and worse with fatigue. It's super important to get back that timing, if you can. Like, I don't know if you can ever get it back to optimal or what it was before. Definitely make it better.
No one really knows their baselines before the injury too. Most people come in post-injury and they're like, well, I was capable of this. But I'm like, it doesn't necessarily mean that they were doing it efficiently. I mean, look at the pro athletes that have difficulty throwing. And they're like, oh, this hurts when I do that. Well, is it really optimal? And are they sure that they have no damage in the shoulder or anywhere else in their body? And that's why you brought up a really good point. Number one, the exercise process that people can focus on a couple different things right off the bat. And for exercise professionals, they can definitely focus on time. What is the tempo? What is the duration? What is the frequency? How are they managing time? Can they do a shortening angle or a lengthening angle? Doing parts of a rep can be just as important as doing the full rep. A repetition being like a start and finish position, right? If people don't know what a repetition is. And it's okay just to hold a position over time, and then what happened during that time? Did you feel fatigue in your body? Did you feel the muscles contracting? Are you okay when you're done doing it? And you can do part of a rep, wait some amount of time, and then try it again, especially if it didn't feel okay. Does it feel better the second time after about 10 to 15 seconds or 20 seconds of rest? Maybe it was the area hadn't done it for a while, and now it's like, whoa, I haven't had that stimulus in a while. Pain, don't organize like that. But the second time you do it, like, oh, it's a little better, or it's worse. You can definitely use that to your advantage while organizing this. Also force, how are you loading this? If you feel a stretch, usually the stretch means you're not controlling it, you're shoving it there. And the body's putting on the brake. So if there's a stretching feeling, I'm like, maybe try to control it better rather than forcing it there. Or if you're doing it, can you feel this thing working? Is there cramping? Cramping usually means you're not capable of organizing the movement efficiently, and you have a full go signal, or not really much at all. Whoa, I gotta go. And now the cramping is there, and now you can't really use the joint because it's dysregulated. You know, it could be from a bunch of different reasons, but more likely than not, you're not capable of using those tissues in that way, at that time, at that load, with that amount of fatigue. So that's why positions, load, duration, and how long to rest are all going to be really, really big deals. And those things can be monitored by anybody. And the PDF that we'll put out is going to have different challenges in it. And I want them to basically focus on how did it feel in their body, what did they do, how long did they do it, can they control it slow to start and light, and then as that progresses, what was that like compared to the unaffected side and the side that's supposedly healthy? Is that okay too? So now you have a comparison side to side, and it's a great starting point to then build up control of the body, because your body gets to take that with you. That is what neuroplasticity and building tissue and control is all about. You brought up really good points, man. Is there anything you want to add?
I don't think so.
Does this help at all? Or? Cool.